I will be talking about what pediatric pulmonary rehabilitation is all about. There are a few guidelines for the rehabilitation of pediatric patients with pulmonary disease. The goals for rehabilitation of these children are not well established, and there are few evidence-based strategies. In adult patients, pulmonary rehabilitation aims to reduce symptoms, optimize functional status, and increase in participation through multidisciplinary, patient-centered approach. Rehabilitation of the pediatric patient can be challenging. The child's age and developmental level can interfere with traditional adult rehabilitation practices. They require encouraging and supportive environment. They also have a strong desire to join with play, sports, and other activities. Rehabilitation of pediatric patients can also be rewarding. In general, children have more rehabilitation potential than adults. Because lung development continues into young adulthood, some chronic pulmonary diseases can improve with age. However, even diseases with progressive decline in pulmonary function over time, there can be greater capacity for healing. The pediatric patient can be incredibly resilient both physically and emotionally. What are the definition and goals of pulmonary rehabilitation? Pulmonary rehabilitation is a comprehensive intervention based on a thorough evaluation of the patient followed by personalized therapies which include muscle training, education, psychosocial intervention, and changes in life habits in order to improve the physical and psychological condition of people with chronic respiratory diseases, as well as monitoring adherence to healthy behaviors that improve their quality of life in the long term. Important components of successful pulmonary rehabilitation are patient assessment, exercise training, education, nutrition, and psychosocial support. The team in charge of the pulmonary rehabilitation program should ideally be composed of pediatric pulmonologist, respiratory physiotherapist, nurse, occupational therapist, nutritionist, psychologist, speech therapist, and a social worker. In addition, specialists such as psychiatrists, neurologists, and others that are necessary to meet the requirements of each child should also be included. However, the members of the pulmonary rehabilitation team will depend upon the resources of an institution or the availability of the personnel. Older children and adolescents may be able to participate in a PR-structured program in a similar fashion to adult programs, but younger children are unlikely to be able to do the same types of exercises and interventions. Effective pediatric pulmonary rehabilitation must be individually tailored to a child's age, functional capacity, and psychological ability to engage. The goal should be focused on reducing symptoms and exacerbations, increasing tolerance to exercise, and increasing participation in educational, recreational, and social activities with the corresponding increase in quality of life. What then are the benefits, indications, and contraindications in pediatric pulmonary rehabilitation? Pulmonary rehabilitation programs include prevention, early recognition, and treatment of morbidities, and inpatient, outpatient, and extended care of patients with chronic respiratory illness. For patients with pulmonary impairment, disability can be due to muscle dysfunction, primary skeletal or cardiopulmonary pathology, poor endurance, or some combination impairments. The patient can be handicapped further by inadequate finances, inadequate family support or education, and various public policies. A successful rehabilitation program identifies and differentiates the disease process so that remedial strategies can be determined. The functional consequences of these impairments are addressed to that person with chronic respiratory impairment is returned to the fullest possible physical, mental, social, and economic independence. The effectiveness of a comprehensive pulmonary rehabilitation program has been established by controlled clinical trials as well. Several impairments such as weakness, dysfunction of peripheral and respiratory muscles, anxiety and depression, and abnormalities of nutrition have responded to treatment. Improvements in exertional dyspnea as well as health-related quality of life have been documented. Significant increases in muscle exercise capacity, as measured during exercise testing, has also been observed. Who are good candidates for outpatient pediatric pulmonary rehabilitation? So, any child with chronic breathing difficulties may benefit from pediatric pulmonary rehabilitation, such as the following. The following conditions are absolute contraindications for enrollment in outpatient pulmonary rehabilitation program. What are the components of a pulmonary rehabilitation program? These are the most important parts of a pulmonary rehabilitation program: assessment and exercise training, education, and psychosocial support. The 6-minute walk test is considered a self-paced, submaximal exercise test since it does not reach a maximum level of oxygen consumption. The strongest indication for the 6-minute walk test is for measuring the response to medical interventions in patients with moderate to severe heart or lung disease. This has also been used to measure response to medical interventions, one-time measure of functional status of patients for pulmonary rehabilitation and other respiratory conditions. The information provided by a 6-minute walk test should be considered complementary to the cardiopulmonary exercise testing and not a replacement for it. To carry out the test, an ideally roofed place is needed, which must have a corridor of 30 to 50 meters long, with cones located 50 centimeters before each end, where the child can walk for 6 minutes. In case the child stops, this should be recorded, but the test is completed when reaching 6 minutes. The 6-minute walk distance is the primary outcome of 6-minute walk tests and is reported in meters. Incremental shuttle walk test is an externally paced maximal exercise test. The speed of walking is controlled by a series of pre-recorded signals, and the speed of walking increases until the participant can no longer continue. The maximum duration of the test is 20 minutes, and it provokes a similar physiological response to a CPET. The primary outcome of the incremental shuttle walk test is distance, reported as an accumulation of a 10-meter length. The speed that the participant walks is chosen from 16 available speeds, with the speed calculated from the performance on the incremental shuttle walk test. Cardiopulmonary exercise testing is a laboratory test that measures workload during exercise and analyzes the physiological components of oxygen consumption. In addition, it allows the identification of the mechanisms that limit the ability to exercise, such as the respiratory, cardiovascular, or metabolic systems, or deconditioning. Owing to its high reproducibility and repeatability, it is a gold standard of exercise tests. It can be performed on most children from 6 years old. Its utility lies in establishing the maximum training load and detecting which symptoms limit the maximum exercise. So these are the indications for CPET. Now, this is the absolute contraindications for CPET. And these are the relative contraindications. General physical training is sustained activity of the skeletal muscles with a set up intensity and duration, which produces adaptive changes in their structure and their performance. Physical training is a fundamental part of a pulmonary rehabilitation program. We define training as a process through which organs and systems are stimulated periodically and systemically in order to obtain a specific response dependent on the stimulus applied. The subject's initial physical capacity must always be taken into account. The professional should be highly trained in exercise physiology, indications, and muscular training programming, knowing its beneficial and harmful effects. Moderate to vigorous physical activity increases exercise tolerance in children with pulmonary conditions, increases work capacity, improves cardiorespiratory fitness, respiratory and peripheral muscles endurance, and contributes to improved immune function. General exercise programs performed on a daily basis improve aerobic physical capacity, work capacity, and maximal oxygen consumption in children. This table shows the recommendations and guidelines for physical training in pediatric pulmonary rehabilitation. The exercise intensity is 60 to 80% of the maximal work rate if the patient was able to undergo CPET, and if CPET is not done or unavailable, we can calculate the intensity using the 60 to 80% of the average speed in 6-minute walk test or heart rate reserve. Exercise training type may be continuous on interval. This may be done 2 to 3 times per week, and the duration should be at least 30 minutes with a total of 24 sessions. We cannot overemphasize the importance of education. Education is a fundamental component in the success of a pulmonary rehabilitation program. It must be done by all professional team and focus on improving therapeutic compliance and promoting a healthy lifestyle. Supervision of the indicated treatment, in particular of the inhaled drugs, checking periodically their use and good execution, recognition of early symptoms on the part of the patient for timely detection of exacerbation, and information about benefits of physical exercise and a balanced diet. Psychological distress, anxiety, and depression are common in individuals with chronic respiratory diseases, especially among older children and teenagers, and their parents as well. These are often accompanied by stigma and shame associated with perceived blame for the disease presence. This can be identified using psychological assessment, employing both questionnaires and a detailed clinical review. The inclusion of psychological support is recognized in the international guidelines for pulmonary rehabilitation. Patient testimonies, positive social support, monitoring of progress, and sustained encouragement from compassionate pulmonary rehabilitation providers may help alleviate these psychological aspects with the help of specialists such as our psychiatrists. So these are the steps in our pulmonary rehabilitation in the Philippine Heart Center. So we should have a request from an attending physician for possible enrollment in pulmonary rehabilitation. Then we have the evaluation of the patient's pulmonary status by the Pediatric Pulmonary Rehabilitation Fellow. Then we proceed to the interview of the patient together with the parents or the guardian. We have to do pre-assessment using the assessment of quality of life, using the pediatric quality of life and satisfaction questionnaire and parental stress scale, together with the 6-minute walk test, incremental shuttle walk test, or cardiopulmonary exercise testing. And once we did do that, They may proceed to the exercise training sessions under the supervision of the clinical research fellow and a respiratory therapist, done 2 to 3 times a week for a total of 24 sessions and at least 30 minutes or per session, along with the different lectures. After that, we will do the post-program evaluation using the same questionnaires and the 6-minute walk test, incremental shuttle walk test, and the cardiopulmonary exercise test. Afterwards, we also hold patients' graduations and discharge.